book the patients for the theater list. And you had the handover from the night team of 4 cases. And the cases are as the following. Case 1, a 25-year-old male patient who presented with an abscess in the left axilla. He doesn't have any high temperature. He never spiked in temperature recently. Blood pressure is normal. Pulse is normal. But the abscess is very painful, and he received some painkillers and seems to be okay. And is currently on theater list for incision and drainage. He has background history of diabetes, and he's currently controlled by insulin. Okay?
Okay.
That's the first case. The second case is a 5-year-old boy who presented with query perforated appendix. The abdomen has an element of peritonitis. There is some sort of tenderness and rebound tenderness on the right inferior quadrant. He spiked in temperature multiple times overnight. The blood pressure currently is borderline, and the temperature 38, despite taking paracetamol. And the pulse is on the higher side. The CRP and white blood cells are high, and he did not have any ultrasound scan. That's the second patient. The third patient is you have a 63-year-old male patient who does not have any previous medical condition, does not take any medication, was booked in an elective theater for hernia repair. He doesn't have any issue with his hernia, it's just elective repair. Okay?
Okay.
The fourth case is a 55-year-old female patient who presented to A&E after not opening her bowel and not passing flatus for around 3 days now. She had a previous hysterectomy, and her current observation include borderline blood pressure, borderline high blood pressure. It is not like 90/60. It might be 105/65 or 70. And she's not tachycardic, and she doesn't have high temperature. You examined her abdomen. She's distended, a little bit tense, but not peritonitic, and obviously not passing flatus and not passing a stool. You've done the PR examination. There's no fecal loading. And in terms of the bloods that we had, the CRP is 16, the white blood cells is 11.4, and the neutrophils is normal, and otherwise all the other bloods are normal. She doesn't have any past medical history, but she had hysterectomy done to her, and that was like 10 years ago. And the hysterectomy was open and transabdominal. Yeah, these are the 4 cases. I'm gonna give you 5 minutes maximum, but if you finished early, just let me know. Think about the case and call me as your consultant, as a general surgery consultant, to discuss the theater list with me before booking it.
Sure.
Yeah, when you're ready, pick up the phone and call your consultant.
Hello. This is Dr. Samir, the surgical doctor here, calling for the surgical consultant. Can I please confirm your name, please?
Hi, Samir. It's Abdullah here. What's up? How can I help?
Hi, Abdullah, Dr. Abdullah. I just wanted to, this call is regarding the booking of the theater list. So I just wanted to talk to you about that.
Yeah, of course. Tell me.
Yes. So I have 4 patients here today. The first that I wanted to put on priority is a 5-year-old male child who is having a suspected perforated appendix. On examination, the patient has signs of peritonitis. He has an increased temperature. His blood pressure and pulse rate are both suggesting a shock-like condition. The patient has fever, and his bloods show a raised CRP as well as leukocytosis. Up till now, we haven't got the ultrasound done for this patient.
Would you like to get the
Uh,
ultrasound first, or are you going to take him?
the clinical condition suggests that I think we should take the patient up urgently and move on from there.
Okay, is he currently in fluids at all?
I haven't. I'll have to check that and get back to you.
Okay, and what is the exact blood pressure? Do you have a number for it?
Uh, Not exactly.
Okay. And where is he now? Is he under the peds or under us? Is he in the
Uh,
peds ward, or where is he?
he's in. I'll have to check that as well in the documents.
Okay, that's fine. So do you think that he needs to go first on the list?
Yes.
Okay, that's fine. I think I agree with you. If you're happy just to carry on with the case, and I will take maybe 1 or 2 hour or 1.5 hour until I be able to come to the hospital. But if you're happy to start, just to start with the case and let me know if there's anything.
Okay. Okay, doctor. The next case that
Can
I
I
want to
just
talk to you
ask,
about.
Samir, have you done the surgery before? Have you done appendectomy before?
I haven't done it independently, but I have done it under supervision.
So who's gonna supervise you then?
Yes, I think I'm pretty confident to start, but I would hope that you come in.
Will you be able to get any assistant to help you to hold the camera at least?
Yes, I will have to check who is on duty right now in the surgery department, and I'm sure I can find someone to assist me with that.
Oh, okay, fair enough. Yeah, I'm not gonna come in until 1.5 hour. But if you're happy to crack on, just crack on.
Yes.
Okay.
The next
What's the next
Yeah,
one?
the next patient is a 35-year-old female who came to the emergency department with symptoms of obstruction. She hasn't passed stools or gas for the last 3 days. Her vitals are pretty good. She has a normal pulse rate. There's no temperature. The BP is borderline around 100, 560. Uh, she has, on examination, she had a distended abdomen, but there are no signs of peritonitis. Um, I did a digital rectal exam and I could not find any pieces there. She has an old history of a hysterectomy done 10 years ago. Her blood workup is okay. She has a leukocytosis. Her CRP is in the normal range,
Hold
and
on, hold on. Why did she have a CT? I'm
I'll
sorry
have to
to
check,
interrupt
doctor.
you, but did she have a CT?
I'll have to check that, doctor. I don't have that in my documents.
But why are you putting her on the theater list if she doesn't have a CT scan, or you're not sure? We can't really take her to theater without CT, can we? Is she very unwell?
She's managing well right now. She doesn't have
Yeah.
any kind of signs that would require her to be taken urgently.
Hmm. Do you think she needs to go to theater, or can we do anything
Uh,
else?
I think because it's been 3 days and she has no signs of even a feces in her on digital rectal exam, I think patient needs to be explored owing to the old history of a hysterectomy. So there might be strictures as well.
Okay. Yeah, fair enough. But I think if she's stable, I will get a CT scan first. So are you able to book a CT scan for her? And let's see if there is any adhesions or something we can take her. But if not, yeah, we can just try the gastrographin, and then we'll see what happens after that.
Okay.
Okay.
The next
What else
patient
do you
is
have?
a 25-year-old male who had an abscess in his left axilla. He too is doing well. He doesn't have a temperature, but his pulse rate and BP are also in the normal range. The issue here is that he has a lot of pain, but I gave him some analgesics for that, and he has improved slightly after that. And I've planned him for an incision and drainage. And his previous history, the only positive finding is that he's a diabetic and on insulin.
Okay, right. Is he fasting or not?
I'll have to check his notes, doctor, to let you know about the fasting status.
Yeah, we just want to make sure that if he's fasting to be on the VRII, just in case. All right. So you said there is one more, is it?
Yeah, another case of a 63-year-old male patient, but he's an elective case for a hernia repair. He has no signs of any strangulation or obstruction, and this can be kept at the least priority right now.
Okay. So you think this one can wait, I believe, right?
Yes, I think it can.
Okay. Fair enough. All right. Good. So what have we agreed on so far? What would you like to do after this discussion?
I think I'd go ahead and get the 5-year-old child in first, and make sure that I find an assistant so that we can get on with that, and so that we are through some of the steps before you reach. And post that, we can get a CT done for the female with the obstructive symptoms, and if there is any signs of severe adhesions and impending rupture, we can put her next on the list. Uh, the patient with the abscess would go on after that, because we'd like to get an infected patient done last. And since he's doing well on painkillers, we can hold him on to keep him on at a later stage. And lastly, if time permits, we can go ahead with the 63-year-old male patient, and get the hernia repair. I'll make sure that I'll check the fasting status of the abscess patient before we can get him.
Okay. All right. Fair enough. Okay. I think yeah, I sort of agree with you, but I think we ideally we should start by the appendix. That's right, and get the CT scan for the lady while the appendix is being done. Go and
Yes.
speak with radiology and let them know to get the CT scan done as soon as possible. And when you're done by the appendix, the CT would have happened. Review the CT scan and decide. But put the diabetic patient, the abscess, second in the list. Meanwhile, which I think the lady with the bowel obstruction might be conservative in the first instance, and if not, we can do her in the afternoon. And the last one will be, yeah, like you said, would be the hernia if we do have time. If not, we can speak with the coordinator and let them know to arrange, another time for the patient maybe later on. Okay.
Yes, doctor, I agree.
All right. Thank you. Bye.
Thank, thank you,
Okay.
so much.
So Samir, what do you think?
This is the first time I've done this theater list. I don't know. I don't have it in my notes, so I'm not really sure what to
So
judge it by.
what do you think of your performance? If you're gonna reflect on it, what do you think of your performance?
I think I relayed the information pretty well, and with the CEP or the protocols, I think this was the right order as well.
Yeah.
And maybe I should have made it a little more concise, the information, and a little more streamlined. Start with inspectory findings, then go on to the EWS, then to the bloods, and finally
Yeah.
the radiology.
Yeah, I agree. Yeah, well done. Yeah, that's actually a very good reflection. So you're aware of what needs to improve. That's really good. So I think I would start this scenario by saying, uh, "Hello, this is Abdullah here. I'm one of the doctors, and I'm calling you to discuss the theater list with you. Can I confirm I'm speaking with my consultant, Mr. X? Yes, I'm Mr. X. So I will say at the beginning, I'm calling you to discuss 4 potential cases on the theater list, and that includes an appendix of 5-year-old and an abscess of 25-year-old diabetic and query bowel obstruction for 63-year-old lady with hysterectomy who didn't have any, who had surgery, who had hysterectomy before, and finally an elective hernia repair. So starting by the appendix, this 5-year-old presented with right inferior quadrant pain, query presence of peritonitis, tender and rebound tenderness, high white blood cells, high CRP, no ultrasound, but I think he needs to go to theater urgently without having to wait for the ultrasound. Okay, because it's quiet and well. If he started asking me about the fluids, I will simply say, I don't know, I will have to go and check. If he asked me about numbers, if I have it in my notes, I will answer If not, I don't know. I'll have to go and check. I think the second case that I will discuss in this, I will go for the abscess. Okay, he's diabetic. He's an insulin. I will need to check if he's currently on VRI or not, and the check if he's fasting. But I think we can keep this second in the list. However, I would like to keep my anesthetist colleague in the loop. I'll go and speak with them and let them know if they agree with that, because it could be a quite quick case to do it before lunch, because obviously the anesthetists need to have lunch as well at 1. So it could be a good case to do it before lunch, while the CT for the bowel obstruction lady is being done. And about the bowel obstruction lady, she is 65, came with this and this and this and this. However, the CT did not happen yet. I believe we might get a CT scan first and then decide whether we can go with conservative management or surgical management. I will speak with the radiologist after I finish my call with you to discuss with them the need for urgent CT scan. And in the meantime, I'll keep the patient fasting and I will keep resuscitating her. And I will also let my anesthetist colleague and the theater team aware of her, because that case could potentially be early afternoon or maybe late morning. So I will let them know as well. For the elective hernia repair, I think the patient does not have any medical issue. There is no concern. It's an elective hernia repair. I will speak with, I will keep him on the list. However, I will speak with him as well and let him know the current situation. And if he's happy to wait and being fasted till the end of the day, and if we have time, we can do the case. And if not, I'll tell him clearly that we have to rearrange later on. So I'll give the patient the choice and see what he thinks. Okay, so I think that would be my arrangement and that would be my presentation. The important points, the important take here is point 1, you summarized at the beginning. So summarization will get the attention of your consultant and he will start listening to you. And instead of making each case like a mystery, he doesn't know what's happening. So you start the case, 5-year-old, this and this, and then at the end, appendicitis, 63-year-old, this and this, and then at the end, bowel obstruction. So just to start by clearly stating the potential cases, so you will get his attention. The second thing is you took the initiative in calling the radiologist to get the CT scan done, and also you query the decision that was done before, which means you're confident of your knowledge and so on, which is the bowel obstruction. And also you took the initiative to speak with the anesthetist, and also took the initiative to communicate with the patient and involve everyone in the loop. Okay, so I think the main thing here is to make sure that you're able to communicate with everyone and you're actually a problem solver. You're trying to solve all the problems for your consultant. The other thing is, which I asked you, I think that was the big mistake that happened in your case, Samir, which you need to really focus on that. So the MRCS exam is an exam from foundation doctors till ST2. So after ST2, you're in a specialty training, and then you will have to do FRCS after that. So the MRCS exam is really at a junior level. You might be a junior and you're able to do an appendectomy on your own, okay? And you haven't been you've been supervised and you're currently very perfect doing appendicectomy. But being a child 5 years old, that could be problematic for you. Being perforated, that could be problematic to you. The patient is currently unwell, you will definitely need support in this patient. That's one. So even if you're confident doing it, you would ask your consultant, no, I would like you to come and join me if that's okay. I've only done it supervised before, and I don't think that I would be able to do it on my own, so I would like you to come if you're able to. Okay? If the consultant said, well, I'm busy, I can't come now, he's on call, he needs to come, but very politely, you need to explain to him, so what would you like me to do? I'm unable to do it on my own, and I think the patient is urgent to go to theater. Are you able to call any alternative to cover you, or are you able to come yourself? Very politely and nicely, and the consultant needs to come. And in this particular scenario, the consultant would say, yes, I'm happy to come. So in my opinion, as a CT2, you're not expected to be doing anything in your own already. Okay, and I'm generalizing, you're not expecting to do anything. Okay, maybe when you're applying for ST3, you should be expected that you have done a few appendectomy as a supervised trainee from 12 to 100. Okay, So it's really up to you. It doesn't matter how many you've done. In this particular case, in my opinion, you need further support from someone who's more senior than you. Okay? So I think if I'm gonna revise this scenario to you, I think that was the main mistake that I wouldn't do. Okay?
Okay. But
All
otherwise,
right. Yeah, I think you've done well. Otherwise, your communication is okay, but it's just a few issues, which is
yeah,
summarizing at the beginning, summarizing at the end.
that makes a lot of sense. Yes.
Yeah, exactly. Summarizing at the beginning, summarizing at the end, taking the initiative. That will make the scenario a little bit better. All right.
Yes. Perfect.
Okay. Thanks, everyone. I'll have to go now, and thanks for joining me today.
Thank you.
Thank you. Bye.